Ever heard of universal health coverage? It's a big buzzword in global policy circles. Sounds promising. Or is it? In many countries of the global south, it's implemented through publicly funded health insurance for people to purchase a limited set of services. Too often, it's private healthcare providers that benefit most. They tend to use public money to promote high-cost procedures, draining human resources from public facilities and developing infrastructure only where profitable. But health is a human right, and public funds should go towards equitable public health care. An emphasis on insurance-based coverage skews public health priorities and pulls us further away from health for all. That's what's happening in India, where the government is using a health insurance model first implemented in the state of Andhra Pradesh. One study shows the scheme for hospital-based care has used 25% of the state's health budget to address only 2% of the burden of disease, excluding common conditions such as TB and diabetes. And because private facilities have received over 75% of total payments, it's weakened the public system and starved primary care. Is that the way towards universal health? We think not. There's no denying that public health services in India suffer from access and quality gaps. But the public system only gets 20% of the national health budget. And despite such underfunding, it provides 30% of hospital care and virtually all preventive care in the country. There are public alternatives to build upon. The National Rural Health Mission, for example, has improved public health facilities and deployed more health workers in rural areas. Tamil Nadu has pulled drug purchase and rationalized distribution in public health facilities where medicines are now available at no cost to patients. Sustainable public sector innovations like these are the real solution. Coverage won't cut it. Health care that is public and universal is possible in the global south. Health workers, activists, and citizens around the world are joining forces to make it happen. Health systems face all kinds of challenges, but the public path to universal health care holds the promise of comprehensive, integrated, and quality services based on primary health principles, more accountability and participation, improved equity, and greater solidarity. Will you be part of the change?
Hi, thank you, Chairman. When I first saw this proposal, my thought was, is this for the Hong Kong people or for your political agenda? It makes very little economic sense. I'll mention that first. It is currently, Hong Kong has currently the second most expensive healthcare plan in the world, and right after the Americans, who are now the largest economy but also going bankrupt because of their commitment to the bottomless pit of healthcare budget. In 1963, Lyndon Johnson had declared an unconditional war on poverty. And now what do we have? We have healthcare spending in the U.S. that has increased 12 times, and also families who don't work for 3 generations because they earn more taking checks than working and paying taxes. So back to the medical plan. Currently, the Hong Kong's coroner's court takes care of medical malpractice and should have no problem to continue doing so. And a government takeover would be breaching the basic law, may I remind you, following in the footsteps of our friends up north. And I'm sure we're familiar with the standards of that system. In terms of increased regulation, that can only restrict medical supply, and in this case would be the good doctors, fresh supply of doctors. So eventually only the rich can go abroad and afford to go abroad and receive the right treatment by the right doctor, and this would be the only group in Hong Kong that can reap the benefits of the voluntary healthcare insurance in the future, only in time. So I think I'd suggest to think harder before entertaining this proposal. And considering that Hong Kong people live longest on earth currently, beating Japan, I don't think we need increased facility regulation. What we do need is a continued fresh supply of doctors to rescue the shorthanded medical system, and that hopefully Hong Kong people can entrust their health and lives to their own medical system again soon. So I ask you again, is politics more important than the lives of our people? Thank you, Chairman.
Thank you. 跟住咧就係
Millions of us now have health insurance under the Affordable Care Act, or what some people call Obamacare. But like many things in life, your health insurance can often be confusing and complicated. Whether you've been insured for years or you're new to the game, understanding your policy is important to your health and your wallet. First things first, you have to pay your premium every month or your insurance could get canceled, kind of like your cable subscription. You can also think of it like a shared healthcare piggy bank. We all chip in each month, even if we're healthy, so the money is there when we need it. If you get insurance at work, your employer probably pays most of your premium, and the rest comes out of your paycheck automatically. If you have Medicaid, you most likely don't have to pay any premium at all. The federal government and your state take care of that. If you're insured through a new health insurance marketplace, depending on your income, you may be eligible for a tax credit that pays a portion of your premium. Once you have that shiny new insurance card, you'll want to try really hard to keep it in your wallet. To better your odds at staying healthy, be sure to take advantage of the free preventive services that all new insurance plans provide. But of course, stuff happens. And that's when insurance really comes in handy. Now, having insurance helps a lot, but it doesn't mean all your health care is going to be free. There are lots of details about your insurance plan that affect how much you pay when you get sick or injured. If you have Medicaid, a lot of these services could very well be free. Otherwise, you'll likely have to pay something when you go to the doctor or fill a prescription. This is called a copay when it's a specific dollar amount, like $25 per visit, or coinsurance if it's a percentage of the bill. There's also the deductible. That's how much comes out of your own pocket before your insurance starts paying. Depending on your plan, you might have a deductible for all your care, or it might only apply to some types of care, like hospital stays and prescriptions. So read your plan material, because it could add up to thousands of dollars. Another important part of your plan is the out-of-pocket maximum. This is the most you'll ever have to pay in any 1 year, at least for the benefits your plan covers. Your insurer will pay 100% of anything beyond the maximum for the rest of the year. It can be just as confusing dealing with prescriptions. Your plan has a list of drugs it will pay for, called a formulary, but the prices vary. Check with your doctor or pharmacist because a generic drug might fix you up the same as a brand name drug, but the price difference could be huge. So, those are the costs typically involved. But remember that they'll be affected by your insurance plan's provider network. This is a list of doctors and hospitals that are connected to your plan. Insurance companies negotiate discounts with these providers. Stay in network and the discounts get passed to you. Go out of network, and you could end up paying full price. And remember that out-of-pocket limit? It won't work if you go out of network. In some plans, like HMOs or EPOs, your insurance would pay nothing if you go out of network. In other plans, like PPOs, your insurance will cover you no matter where you go, but you'll pay a lot more if you go out of network. Also, if you want to visit a specialist, like an orthopedist, some plans require a referral from your primary care doctor. Sound easy enough? Well, sometimes staying in network can be tricky. In a hospital, it's possible that your surgeon could be in network while your anesthesiologist is not. If this happens to you, don't be afraid to negotiate with your provider or file an appeal with your insurer. So as you can see, there's a lot to think about when you choose an insurance plan each year. Some plans may have low premiums, but fewer doctors or hospitals and high deductibles. There are trade-offs, and understanding and choosing among plans isn't always easy. Remember, if you have questions, call your health plan and ask, or check with your hospital or doctor. If you still have questions, your state insurance department or consumer assistance program can help. With the Affordable Care Act, there's new support for consumers, so take advantage of it. Having health insurance protection is a good thing, especially when you know how it works. We hope you're now better prepared for the next time you have to pull that insurance card out of your wallet. Stay safe, America.
Yes, and Sitra gave us the assignment to think of what the healthcare could look like in Finland year 2030. You can see our group on the stage at the moment. Here we have Eero and Henrikki from the Bioinformation Technology from Aalto University. On the last corner with Christian from the Helsinki University Faculty of Medicine, and myself, Nelly, from the Information Networks from Aalto University. We had the honor to interview some great experts from the field of medicine and science. On this slide you can see our interview is listed. Let's take a quick glance of the structure of our presentation. First we're going to talk a little bit about Finland year 2030. Then we're going to jump over to the healthcare system, and afterwards to data and see how these two relate to each other. And the last topics will be e-health and the changing roles within medicine in future. So, we all know we're going to face some challenges within the next 15 years. We have raised some of the challenges on this slide. These were mentioned by all of our interviewees. To tackle these challenges, we need to react and rebuild our existing systems. Otherwise, we're going to face some difficulties. What to do about this then? Christian will tell us a little bit more about the healthcare system's point of view.
Thanks, Nelly. We looked at the Finnish healthcare system from an economical perspective, and we divided our inspection into public and private sectors. Let's take first look on the public sector. As all of us know, the Finnish healthcare system faces some dramatic challenges in the near future. Here are some of the problems that our interviewees brought up. Let's take the weak incentives as an example. In many municipalities, it is often the case that the only target of the healthcare department is just to comply with the minimum requirements of the legislation. It is obvious that this doesn't always lead to decisions that would maximize the health benefits at a populational level. In this other part, we have visioned some of the possible solutions to these problems. For example, integrating services helps in promoting the overall health benefits. As we know, all of the health outcomes are not created in the healthcare sector alone. Let's move on to the private sector. We predict that competition will increase in the private healthcare market. There are three reasons to this: new service concepts, new pricing strategies, and competition from other industries. We have gathered here some case examples from all these three topics. First, Virtual, a US-based company, offers fast diagnosis and treatment plan completely online. Below you can see some savings that they have estimated the patient to make by using the service. Next, Finnish Healthy offers occupational health services at a fixed monthly rate. This gives them the incentive to keep their customers, employees, as healthy as possible, and in the case that they do get sick, keep the treatment processes as simple as possible. PK Terveys is affiliated with the S Group, and they have their practice located at a Prisma supermarket. They offer reward points from their service fees, just as the other sectors in the S Group. So this is clearly a new type of player in the healthcare market. In this figure, we have presented some of the different service models in the healthcare sector. In the left, you can see Virtual, which I mentioned earlier, that requires the least contact. And on the right, a traditional health service, such as a doctor's appointment. Great. Next, Henkka will give us some insights about data-driven healthcare.
Thank you, Christian. Okay, so technology, obviously a great facilitator on the medical field. We can roughly divide it into existing and new technologies. Existing are the ones that are already in clinical use, such as medical imaging in its many appliances. It will get more common in use and cheaper. We could have MRI imaging in your local mall in the future. New technologies, on the other hand, are those that may not have a clinical use yet, but they will get developed further, and in 15 years we could see some new ones being in use. Bioprinting, for an example, is not maybe the most likely one to appear in the next 15 years, but there's a possibility. An important aspect also is our breakthroughs. There's a good example, genome sequencing, which has gone from $100 million per person to a mere $1,000 per person in just 15 years. So there's a lot to be gained here, but it's hard to predict what will happen. Next, we will look at big data, a huge buzzword nowadays, and for a good reason. The data explosion is already happening, and it will only increase in speed. There are estimates that by 2020, the world will see tens of billions of terabytes of data, which is obviously an enormous amount, and there's a problem in how are we gonna utilize that data. This will obviously also apply to the medical field. By 2030, who knows? The figure could be much bigger. There's also a problem in that we can't really process all this data, even at the current rate of progress. But even the current rate might not keep going. There are estimates that Moore's law will not keep up, and here we see a big problem. But solutions, there may be some, but we don't know yet. Quantum computing, the breakthrough, could solve everything. And next we will look at some examples of how big data is utilized today in medical healthcare. Asthmapolis is a company that monitors location and dose data from asthma inhalators and tries to, for example, predict symptoms in patients to pollen in some areas, for example. Influenza obviously has a big impact on the populace, and there are numerous companies trying to predict its spread in the population. Some of them even utilize social media status updates. GNS Healthcare is a company that's trying to predict the outbreak of metabolic syndromes in its patients, and they do this by gathering a large amount of data and looking for risk factors in certain groups of patients. Cancer research has numerous programs. There's a very large one called the Moonshots program, which has a wide variety of ways that they are utilizing big data, both in research and in treatment. And our final example, Alzheimer. There are companies that are looking at patients' movement data on a daily basis and gathering it to monitor the progress of the disease. And next, Eero will tell us something about eHealth.
Thank you, Henkka. We believe that eHealth will be an important part of Finnish healthcare in 15 years. And next we'll show a few examples of possible service concepts. A good example of eDoctor is Medoc, where you can consult the doctor remotely with a video connection on your phone. This kind of service improves the availability of medical services. For example, specialists can treat patients anywhere in the world. Next we'll have e-measurements. The Taito platform and device is a good example of this. It will be released soon at around a $200 price rate. You can, for example, take a picture of your throat and ears and send it to the doctor, who can use it to diagnose remotely. The point of virtual health check and coaching is that it's available anytime, anywhere. And it requires no active work from a professional. A good example of this is Duodecim's electronic health check and coaching, where first you'll fill a survey of questions about your lifestyle, and then you'll get an individual lifetime expectancy and a 12-week coaching program to improve your lifestyle habits. Remote monitoring and sensors enable faster return from the hospital. They can also be used in the treatment of chronic diseases. Good example is Google's and Novartis contact lens for diabetics, which allow continuous blood sugar measurement. One of the biggest pros of eHealth is that it saves the patient's time. You don't have to wait at the health center. It's also one way of enabling services for less populated areas of Finland, for example. And there are, of course, limitations to, for example, you can't take a blood test on a remote connection, now at least. And the attitudes of people are question mark. Will they allow this new type of service to blossom? And here are the different services by their need for professionals and their need for premises. And next, Christian will tell us about the changing roles.
Thanks, Eero. In this last part, we will talk about the changing roles in healthcare. The role of the patient is going to increase, and there are two reasons to this. First, the amount of easily accessible medical information will continue to increase, and we will have better informed patients. Second, the patients will gather more personal health data from themselves. Both these changes still require some kind of attitude change from both the professionals and the patients. And in this slide, we have presented 4 factors that influence the development of the role of the doctors. All these issues, such as medical education, should be carefully considered when developing the future healthcare system. And to finish this up, Nelly will give us some concluding remarks.
So, here's our finishing off graph. We have gathered some of the already existing phenomena and future phenomena on this graph. On the x-axis, you can see the likeliness that the phenomenon has to emerge. And on the y-axis, you can see the effect we consider the phenomenon to have on overall healthcare of the society. For example, we have the structural changes over here, which we think will affect society widely and are almost inevitable to emerge. Then again, we have the integration of the information systems, which we do think would have a great effect, but at least during the next 15 years, we don't consider that as a likely phenomenon to emerge. To finish off, we would like to thank you for your patience and thank Ville Koise for the great and active support we have received throughout the project. And we're of course interested in discussing these topics on a more detailed level. And if you have any questions, don't hesitate to come and ask after Kristina's presentation. We'll be out of the door and on your left-hand side. Thank you.
Thank you. Well, good afternoon. I'm Dr. Richard Pan, and I'm a pediatrician. I've practiced for over 20 years, pediatrics. I'm an educator. I ran the training program at UC Davis, spent time teaching other doctors how to practice. I'm a health services researcher, a student of our healthcare system, and I'm now a legislator working to try to achieve affordable, accessible, quality healthcare for everyone. Thank you. Great. Now, as we're looking at our healthcare system, healthcare has evolved quite a bit over the last century. Physicians in the past, most of the time, healthcare was mainly focused on acute illness or injury. Good physicians would diagnose diseases, but had very limited treatment options. People would come and they'd seek help for an acute illness or injury, but few survived long or lived long with a chronic condition. But fortunately, because of advances we've had in healthcare, we've actually increased life expectancy over 20 years in the past century. In fact, people who used to die at an earlier age are now living with a chronic disease. In fact, right now, 40% of Californians have at least one chronic disease, and we spend about 70-80% of our healthcare spending on taking care of chronic disease. But yet, our healthcare system is still rooted in a time when we were still focusing on acute illness and injury. So what I want you to do is I want you to think about someone who has a chronic illness, a chronic health condition. Perhaps that's a child with asthma, a parent with high blood pressure, a cousin with diabetes, maybe a friend with cancer. And now think a little bit about how they receive health care right now. Right? You have to remember to take your medications, maybe more than once a day, right? You got before and after, 3 times a day. You have to go to the pharmacy, pick up your refills, and then there's doctor's appointments, right? You might have more than one doctor. You have a primary care, a couple specialists. You got to make those doctor's appointments. Maybe have several in the same week, certainly several in the same month, having to miss work or school. And then when you show up, you got that whole list of questions. My God, I have to remember all these questions I have to ask before I leave the door, right? The doctors complain about the hand on the hand on the door question, right, at the end. But you got to get through that list. And then you get sent for some labs or x-rays and hope those results come out. But most terrifyingly is you show up and your doctor looks at you and says, things aren't going so well and we need you to go to the emergency room in the hospital. And in fact, the way we organize our healthcare is really around sort of these episodes of care. When I say episodes of care, I mean around doctor's visits, emergency room visits, hospitalizations, procedures, and tests. But yet, a chronic condition is something you live with all the time. It's an ongoing activity. It's something that you live with every day. It's not just something that you have and you get cured and it's over. And we need to think about how we take care of people when they have chronic conditions. That 40% of people have at least one chronic condition. And people are working on creating these new models of care. It's like the patient-centered medical home. How do we try to coordinate things to be sure that we can take care of people who have chronic conditions more effectively? Now, in the other realm, we have information technology. And we all have our smartphones. Perhaps, I think probably most people here perhaps have one, I don't know. But certainly your computer at home. We have connectivity all over the place. And this information technology actually can increase our capability to take care of chronic illness. Even as it's ubiquitous in our lives, it can help us with this ubiquitous disease that we may have to deal with. Now, right now, we have something called telehealth. And you've probably seen you might have heard of telehealth. Telehealth is when we use telecommunications to deliver healthcare. And in fact, right now, we're using information technology to implement electronic health records, video conferencing with specialists, maybe reading x-rays or taking a look at a picture of your rash remotely. And certainly that is helping us deliver healthcare more efficiently. It's reducing geographic access. And UC Davis here is an international leader in research in telehealth. But the challenge right now in this current generation of telehealth is that we sort of are just using information technology and layering it onto the existing healthcare system. That is, layering it onto these episodes of care, perhaps making these episodes of care more efficient and reducing those geographic barriers, but it's still those episodes of care. And so let's think about how can we use technology to actually change the way we take care of people with chronic illness. That ubiquitous technology can be ubiquitous in trying to figure out how do we take care of people on an ongoing basis, not just in these episodes. And I want to call that virtual health. So virtual health is applying technology from basically centering healthcare delivery from the doctor's office and the hospital to the patient's home, work, and school. And in many ways, even though I'm calling it virtual healthcare or virtual health, it's actually more real than perhaps the healthcare we're getting now, which often takes place distant from where the patient actually lives. In fact, we spend a lot of time in healthcare. In fact, most of healthcare is actually collecting information, then processing it and transmitting it back to patients, back to the patient's doctor and their care team. But that's something perhaps we should be able to do more in people's lives and integrate it more into people's lives instead of pulling people out of their lives to do this, which is what we're doing now. And in fact, for example, some of the things we should think about, each one of us generates a lot of physiological data, a lot of data that we can self-report about our condition. And there are devices right now like Fitbit that collects physiological data unobtrusively, and I think gives you an example of what the technology is capable of. So in virtual health, what we want to do is actually take care of chronic disease on an ongoing basis, not on an episodic basis. Take care of the disease like the disease is itself, something that goes on all the time. So just as an example, I want to talk about a patient, we'll just call him Tim. Tim has persistent asthma, and he goes to high school, he's on the basketball team. I'm a pediatrician, so I have to talk about someone who I take care of. And he's been prescribed a controller inhaler to try to keep his symptoms under control. He has what's called a rescue inhaler when he has symptomatic. And then he has a spirometer that measures his lung capacity, so we know how effectively his treatments are going. And so Tim goes to the doctor tells him, you need to take your controller every day, take your rescue inhaler when you have symptoms, take your spirometer and write down the results on this piece of paper. When you come see me next, we'll go over all of this stuff and see how you're doing. Now, one day, Tim goes to school, and he's been coughing and sneezing a little bit, and he's going off to his basketball game. And when he's at basketball, he's feeling a little short of breath. He takes his rescue inhaler. Didn't really feel much better. And then he's on the court, and he's getting more and more short of breath. And finally, his coach sees him, he's gasping and he's wheezing, calls 911. They take him off to the emergency room. They call his parents. Tim's in the emergency room, you need to go meet him there. They go, the emergency room doctors do their thing, they get him on treatment. Several hours later, anyone been to the emergency room? Okay, it's not just a few hours. Several hours later, he shows up, they stabilize him, and I've been there. We'd say, okay, well, looks like here's your regimen. Follow up with your primary care doctor the next day to go over your asthma management. And so that's what you do. But could we do something differently? And in fact, there are opportunities to keep him from going to the emergency room. And so what I want to do is talk about what would happen if Tim had virtual health. Because after all, we know that 4,600 Americans every day, actually show up in emergency rooms with asthma attacks. So what can we do with virtual health that perhaps might be different? So in virtual health, Tim and his parents, they agreed to ongoing monitoring of his treatment plan. We have innovators to develop devices that could actually measure when he uses his inhaler, how many times he uses it. They actually spirometer, instead of him writing down a diary, it actually transmits the results to his care team. So when he skips taking his controller inhaler, he feels good, so why should I take my medication, right? So he skips taking that controller inhaler, and someone actually says, oh, you didn't take your dose. And it sends him a text and says, by the way, you didn't take your controller today. All right? And if he still doesn't take it, or he skips a few, the care team gives him a call. The nurse gives him a call and says, hey, what's going on? Is there something that's keeping you from using it? Maybe we need to change your medication if this one isn't working for you. All right? So we're going to be sure he takes his controller every day. Now, they also notice that he's using his rescue inhaler a little more, and they go, oh, what's going on here? And they see the spirometer, which has been transmitting the data, goes to the data center, and it looks like your lung capacity is going down a little bit. So they call him up, and they say, so what's going on? It looks like you're having a little more trouble. He might not have even noticed it. He says, well, I've had a sniff and cough, cough and a little sniffle. I said, well, sounds like maybe that's trying to trigger your asthma. In fact, we're going to tell you to increase your controller inhaler. We're going to increase the dosage there to keep you from getting sicker. And let's see what your rescue inhaler is really doing. So take a puff, repeat your spirometry 15 minutes later. And they can actually see the results. And they go, oh, looks like you're doing well. Good. Why don't you go to school? We'll have you on this higher dose. He goes to practice, he uses the spirometer again. Lung measurement looks good. Okay. And then he goes home and he's breathing easily. And so what happened is that his team's able to follow him. And then he gets a call from his doctor and said, looks like the day went really well. We're going to keep you on this higher dose of the controller for another 4 days until your cold blows over. And then we can see whether when your lung capacity is getting better, we can lower the dose later. So this is sort of ongoing real-time care. And in fact, what we're doing is we're collecting key information, we're collecting it, analyzing it, sharing it in real time between patients and their doctor. In fact, the physician-led care team that provides a medical home can continually support the patient and their family. We can reduce avoidable hospitalizations and doctor's visits. In fact, what happens is the doctor's actually communicating with the patient more frequently, but particularly at the time when they really need the care. So it's not just about when you schedule your visit, it's when you actually need them. And this isn't just about asthma. We can do this for diabetes, cardiovascular disease, hypertension, other chronic conditions, self-reported information, hopefully mental health, many other conditions that are chronic diseases. Now, there are many hurdles to overcome before this kind of health, virtual health, is available. You know, our technology is actually present. It's kind of like the Apollo moon mission. The technology was there, they had to put it together to send the man to the moon. That technology is present, but we need to have patients and doctors who want to demand and try these new approaches. We need to figure out how do we integrate information technology, similar to the way the financial services industry perhaps has done. They've transformed our banking system with IT. We need to do the same in healthcare. We've been lagging behind. Anyone remembers the show, The $6 Million Man? Well, the theme was we have the technology, we can rebuild him better, faster, stronger. Well, we have the technology, we can rebuild healthcare, but we need leaders. Leaders who understand healthcare and the doctor-patient relationship and how important that is to success. Leaders who can create an environment to foster innovative changes, innovative devices to establish that data and interconnectivity infrastructure, but who can also transform patient-centered medical homes and care networks that are better serve patients. Leaders who can articulate a vision and bring it to reality. We can re-engineer healthcare to better meet our needs. And together, we can build a healthier future. Thank you.
At V Technologies, we pride ourselves on being the most trusted source for reliable, fast, and accurate processing services in the industry. V Insure is the insurance services division of V Technologies, offering end-to-end healthcare insurance claims processing and administrative services. Under the wings of Sonia University, V has unparalleled access to the best of the best in each graduating class, providing V with the talent needed to deliver the most superior services possible. We have knowledge embedded in our DNA. V owns world-class training facilities and makes quality its top priority, providing rewards and incentives to its staff for meeting and exceeding their quality targets. Our differentiators set us apart from the industry. V is one of the few HIPAA-compliant companies outside of the U.S. and is also fully HIPAA certified by TÜV Rheinland. V uses a unique process which breaks each healthcare claim into 4 parts, and each is handled by a different agent. No one person sees the entire claim, which contains proprietary patient identifying and medical information when together. Employee turnover is a major issue for many India-based BPO firms, but not at V. While most Indian firms experience 30% plus employee churn each year, V has less than 12% churn and about 5% at one major facility. This allows us to deliver the best SLAs in the industry over an extended period of time. In fact, V has never lost a client due to service quality. Our expertise leads into a diverse portfolio of healthcare insurance-related services, ranging from intake and front-end services, claim processing services, claim repricing and provider maintenance, claim payment and adjudication, and related value-added services. Our knowledge base and proven processes allow us to deliver an integrated spectrum of insurance data processing solutions, whether it's providing enrollment and eligibility services, automating COB processes, or provider data management. V Insure executes results around the clock to achieve your specific business goals and objectives. In the past 6 years alone, V Insure has processed more than 50 million claims. What makes V so attractive to our clients is our dedication to premier quality. Improving our clients' flexibility and response, Our talented team can provide an accelerated turnaround time of 12 to 48 hours at Six Sigma quality levels. We believe there's no one-size-fits-all approach when it comes to a medical claims processing system. We have experience in working with all major platforms in the industry, including TriZetto Facets, EMC's ActionPoint, and Captiva. We have also built our own systems and software, which we use for various clients. Claims payment and repricing is a very difficult process. Put vInsure on your side of the equation to get this done right the first time. Our claims adjudication services include verifying eligibility, duplicate claims check, coding, bundling and diagnosis, hospital detail analysis, benefit determination, and rules-based edits. More and more clients are choosing vInsure to handle their enrollment and eligibility process. Our VCAP software validates checks in the system, which then help our enrollment and eligibility specialists search for and clean up demographic discrepancies at the time of the enrolling patients, saving you valuable time and money. U.S. insurance companies pump out $60 billion in fraudulent claims every year. No company can be too protected from this liability. vInsure has the right systems in place, such as provider and fee schedule matching, and provider selection and database validation to guarantee that this doesn't happen to your company. Your best fight against fraud is vInsure. EDI has become a critical strategic business tool for companies to share data. vInsure's EDI system can securely transport your private data between systems and partners with no errors. EDI integration leads to reductions in administrative cost, fewer clerical errors, and lightning-fast transaction cycle times. Other benefits you'll see include improved inventory management, communications, training partner relationships, and customer service. V has established industry-leading security requirements. V's security certifications include SAS 70 Type 2, ISO 27001, and the risk assessment standards of the SEI Carnegie Mellon's Octave tools. V has passed all independent security audits conducted by several leading U.S. insurance providers. Our brand promise is to offer quality in every transaction. With vInsure, we guarantee you trust in every transaction.